Thank you all for being here. I'm Kaz Nelson, Vice Chair of Education, and it's my pleasure to introduce Sasha Zagoloff today. She's one of our PhD level psychologists in our department, and I wanted to share with you a little bit about her training. She got her BA from Emory University in Atlanta, Georgia, her master's in clinical psychology at Illinois Institute of Technology, and she went on to achieve her PhD with highest honors from Illinois Institute of Technology. She went on to complete her internship here at the University of Minnesota in the Department of Pediatrics and Psychiatry. And then her postdoctoral fellowship was back at Emory University School of Medicine in Atlanta, Georgia. She's been on our faculty for a few years now and serves as assistant professor, and then has also recently gone on to be clinic director of our clinic. And so she's really done a lot of amazing things in her short time here, in addition to serving on the Education Council with me, which has been a very rich and personally rewarding experience for me to be able to work with Dr. Zagoloff in this capacity, because we've taken a close look at our practices when it comes to our training activities with learners of various disciplines, and how to not just train side by side doing totally independent things, but recognize there's a shared mission and there may be shared avenues for collaboration and learning, and acknowledging that we all exist together under a similar mission and we can collaborate. And we've made a lot of headwork in that area that I'm very proud of, and it's primarily thanks to Sasha and your colleagues for making that happen. So I'm going to turn it over to you and we can talk more about interprofessional activities.
Great. Thank you, Dr. Nelson. Some of what she just mentioned is like in my notes section on my slides, and I swear I didn't give them to her for her to say them, but we're coordinated, so that's good. All right, so like it says, I will be talking about interprofessional education and collaborative practice, what the rationale is, what the competencies are, and how to get involved. In terms of disclosures, it isn't particularly relevant for the talk, but in the interest of full disclosure, I do get some grant support from a grant that Dr. Bernstein is the PI on, and then I won't be talking about medications or devices at all. So, all right, so what I'm hoping you all take away from this talk, number one is why I get excited about the idea of interprofessional education, and hopefully why I hope you do as well. The second is, what is this whole concept mean? What is already being taught here at the U and what's being taught elsewhere? And then, like I said, if you get excited about this, how you can incorporate it into your own work and get more involved. All right, so what is IPE besides a mouthful? So in 2010, the World Health Organization defined it as when students learn, or when students from two or more professions learn about, from, and with each other in order to enable effective collaboration and improve health outcomes. And so critically what that means, it does not mean just having two learners of different disciplines in the same classroom, not necessarily talking to one another. That's not the mission. A very tiny example that we've got going on in our department that I'm proud of is that right now we've got psychiatry residents and psychology learners in the same classroom learning about cognitive behavioral therapy. And it was music to my ears when in one of the lectures early on, a resident said, "Can you tell me what is the difference between a grad student and an intern, because I don't know and I feel like I should." And I said, yes, thank you for being interested. And then I was able to have one of the grad students explain the difference. So, and it even went further from there, because then we had a discussion about PhDs and PsyDs and MDs and DOs, and none of that was about CBT, but that's okay. So that would be interprofessional education. And then the point of interprofessional education is to get us prepared for interprofessional collaborative practice. So this is when multiple health workers from different backgrounds work together with patients, families, providers of different careers and communities to deliver the highest quality of care. And here I italicized patients. The World Health Organization didn't do that, but simply to reference that it's really critical to be moving in the direction of thinking of patients as a member of their care team. It's not that all of these providers are sort of working for this person, but that they are an integral member. So, and as Dr. Nelson mentioned, the whole point of this is to not be working in silos. And so I think clinic is a perfect example of this, where we've got phenomenal psychiatrists and phenomenal psychologists, wonderful learners of both disciplines. And if you ask me, they don't talk almost ever. but maybe I'm too critical. So, but we could be doing better. So, all right, and so why should everyone in the room and people elsewhere really care about this? So I was really excited when one of the people who recently came to give a talk to be our head actually mentioned the triple aim. However, I was discouraged when he mentioned the triple aim, and the look around the room suggested that nobody knew what it was that he was talking about. Perhaps it's because it was 8 o'clock in the morning, but my guess is that lots of people don't know about the triple aim. And so this is what it is. The goal is to improve the patient experience, to simultaneously improve population health, and then lastly, to reduce per capita cost. So at a very basic level, there are lots of errors in our medical health system that contribute to increased morbidity and mortality. And the worst part about it all is that year after year in the US, we have the highest costs and we don't have any better outcomes. So we got to fix that. And the hope is that collaborative practice is one way to do that. What I'm super excited about, and it didn't come up at the head talk, but that's okay, is this idea of the quadruple aim, which is more recent. And so, as it says there, that the goal is that we should also be talking about provider well-being. So making sure that we're addressing things like burnout, because as we know, burnout is a huge problem. People leave the field, and even if they don't leave the field, it's associated with more mistakes, with lower satisfaction, and therefore higher costs. So if we really want to talk about the first three, some would argue, myself included, that we should talk about the fourth. So just some other rationales. Obviously, with the recent Affordable Care Act, healthcare is changing, and so specifically, affordable care organizations have been created. And one of the objectives of affordable care organizations is specifically to incentivize team-based care, whether it's in patient-centered medical homes or other initiatives. That's the goal, that finally the powers that be are recognizing that team-based care is important. At other more basic levels, there's lots of financial incentives. So as we know, if you can reduce readmissions, there are financial incentives to that, and obviously reduced readmissions would be associated with outcomes and addressing healthcare. No matter what's the discipline in healthcare, we have a huge shortage of providers. A former president of one of the psychological associations was quoted as saying that we could train 10 times the number of mental health care providers, and it still wouldn't do a dent in the mental health care needs. So clearly, whatever the discipline, we need to figure out sort of a different method. And then for those of us who are doing this exceptional work, we need to be more efficient. So on both sides. One great thing is that fortunately people are living longer. The downside of living longer is that often you get more and more complicated medical conditions, which brings more and more providers on board. Improve outcomes is something I'm particularly interested in, just based on some of the work I've been doing in clinic. And so specifically, the thought is, or the hope is, that collaborative practice, and specifically including the patient, can lead to improvements in things like adherence. And so the term adherence by itself, one could argue, is a little paternalistic, as though we as the provider have this brilliant idea if only the patient would adhere to it, and they're just non-compliant and, they're the problem. When perhaps if we re-envision the healthcare system with the patient on the team, that might lead to improved adherence. And then lastly, increased specialization. And I think our department is a great example where we have phenomenal people who are very specialized at what it is that they do. But the problem is that then we have more and more providers on board. And so recently, in fact, there was a kiddo in clinic who, I did not do the evaluation, but they were evaluated for an internalizing disorder. And at the end, one of the suggestions was a referral to another clinic to evaluate for ADHD. Now, it would be nice if we had somebody in clinic who was a psychologist who could do that. But more importantly, the trainee said to me, I don't get it. Why can't you or whoever did the eval evaluate for ADHD? And I was a little embarrassed because the trainee totally is correct. I have been trained in doing ADHD evaluations, and at the same time, when I think about my scope of practice, that's just not one of the things that I include. But so for the patient, as well as then for everyone on the care team, that just requires yet another person, which is a burden. All right, so Eric Dishman, I will show a short little clip. He currently works for Intel, trying to figure out how to use technology to improve healthcare. And when he was in college, I'm only going to show you a small portion of it, and so when he was in college, he was diagnosed with a kidney condition and told, we're really sorry, but you only have 2 to 3 years to live. As you'll see, he's far beyond college, and so he has lived quite a long time. And the part that I will show will really be about the role of teamwork.
At home as the default model. Software is also and the device will say up, down, left, right. Ah, Eric, that's the perfect spot to send that image off to your doctor. Now, if we've got all these network devices that are helping us to do care anywhere, it stands to reason that we also need a team to be able to interact with all of that stuff. And that leads to the second pillar I want to talk about, care networking. We have got to go beyond this paradigm of isolated specialists doing parts care to multidisciplinary teams doing person care. Uncoordinated care today is expensive at best, and it is deadly at worst. 80% of medical errors are actually caused by communication and coordination problems amongst medical team members. I had my own heart scare years ago in graduate school, and we're under treatment for the kidney, and suddenly they're like, oh, we think you have a heart problem. And I have these palpitations that are showing up. They put me through 5 weeks of tests, very expensive, very scary, before the nurse finally notices the piece of paper, my meds list that I've been carrying to every single appointment, and says, oh my gosh, 3 different specialists had prescribed 3 different versions of the same drug to me. I did not have a heart problem. I had an overdose problem. I had a care coordination problem. And this happens to millions of people every year. I want to use technology that we're all working on and making happen to make healthcare a coordinated team sport. Now, this is the most frightening thing to me. Out of all the care I've had in hospitals and clinics around the world, the first time I've ever had a true team-based care experience was at Legacy Good Sam these last 6 months for me to go get this. And this is a picture of my graduation team from Legacy. There's a couple of the folks here. You recognize Dr. Batuk. We just talked to him. There's Jenny, one of the nurses, Allison, who helped manage the transplant list, and a dozen other people who aren't pictured. A pharmacist, a psychologist, a nutritionist, even a financial counselor, Lisa, who helped us deal with all of the insurance hassles. I wept the day I graduated. I should have been happy because I was so well that I could go back to my normal doctors, but I wept because I was so actually connected to this team. And here's the most important part. The other people in this picture are me and my wife, Ashley. Legacy trained us on how to do care for me at home so that they could offload the hospitals and clinics. It's the only way that the model works. My team is actually working in China on one of these sort of self-care models for a project we called Age-Friendly Cities. We're trying to help build a social network that can help track and train the care of seniors caring for themselves, as well as the care provided by their family members or volunteer community health workers, as well as have an exchange network online where, for example, I can donate 3 hours of care a day to your mom if somebody else can help me with transportation and meals, and we exchange all of that online. The most important point I want to make to you about this is the sacred and somewhat over-romanticized doctor-patient one-on-one is a relic of the past. The future of healthcare is smart teams, and you better be on that team for yourself.
Okay, so I have to say that as a psychotherapist, that comment there at the end about the one-on-one relationship being a relic of the past, I had a visceral negative reaction. And at the same time, when I think about it, I don't think that, one, I think when I think about how I actually practice, we are all a part of a team. And more importantly, I don't think that being part of a team has to in any way detract from still having a really important therapeutic relationship, since we do know that that's the most curative factor anyway. He briefly mentioned financial planners. I thought really interestingly at a recent talk, somebody actually mentioned security needing to be part of the team. And so, when you think about like our clinic or the hospital, to put together teams and not have the individuals who are coming and doing restraints and wheeling people seems negligent. And so I just think we have to be really creative and flexible when we're thinking about who's on this team. And lastly, I think everyone in the room has the experience of not only being a provider, but also being a patient. These days, I am a patient fairly frequently, and I certainly hope that all of my providers are talking. And so I think all of us sort of have that experience and know and can resonate with it. All right, so hopefully that has made the point for why we need to be doing interprofessional work and why we need to be training people to do it. And so in 2011, there was a national collaborative put together by the disciplines on the left, where they really came together to say, if healthcare of the future is in teams, what do we need to be teaching learners that we're not currently teaching them? And so the 4 things on the right are the domains that were identified as being the most important when we think about collaborative practice. And I'm certainly hoping that if this gets revised, psychology will be at the table next time. All right, so the first in terms of values and ethics, like it says, is to work with individuals of other professions to maintain a climate of mutual respect and shared values. And then what I've got there in parentheses, like with every profession-specific competency list, there's competencies and then there's subcompetencies. And so an example when it comes to values and ethics is that just like with patient care, we always want to have high standards, but in particular, we need to have high standards when it comes to our participation in a team, that we're not just having high standards for our own patient care, but our relationships with colleagues. Roles and responsibilities is to use the knowledge of one's own role as well as of other professions to assess and address healthcare needs of patients as well as populations. So not only do we need to be aware of our own scope of practice, but know when is something outside of my scope of practice and I should be engaging a professional from a different discipline. Equally important is that we should be knowledgeable about everybody's role on the team. And I certainly am not knowledgeable about everybody's role on the team. And beyond that, you need to be able to communicate that to the patient. So that you can say, this is the pharmacist, he or she does X, Y, Z. This is the nurse, he or she does X, Y, Z, not just your own scope of practice. Communication, so this needs to be with patients, families, the community, and other providers in a way that is responsive and responsible in order to support the team approach. And so an example of this would be that when you are working with a patient, that communication always notes the importance of team-based care. And so there isn't any, oh, that other discipline dropped the ball, blah, 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 because we are all a team. Additionally, I think equally critical is that as a part of a team, you need to always be providing feedback as well as responding and incorporating feedback that you receive from your team members. And so then lastly is the idea of teamwork. So making sure that we're working on relationship building values and team dynamics so that we're performing effectively to deliver patient or population-centered care that is safe, timely, efficient, effective, and equitable. And so this not only talks about some leadership practices in terms of different teamwork strategies and ways that leaders can be involved to make sure that everybody has a voice, but in addition, not only reflecting upon one's own performance, but also reflecting upon the performance of the team. So if that's what needs to be taught, here is how it's taught here at the U. I think it's really fantastic that all of the schools listed on this slide are officially participating in something called One Health through the U. As you can imagine, getting this many schools together and having collaborative educational opportunities is quite the task. For those who may not know, because I did not, allied health represents occupational therapy as well as lab sciences. And then MHA is a master's in healthcare administration. And speaking of allied health, when I facilitated this class, there was somebody from lab sciences who specifically talked about feeling like the lab always gets blamed. So if there's any sort of problem with results, with communication, it's always the lab's fault. And part of that is that no one ever interacts with the lab, because they're people too. So, all right, and so this is what the curriculum looks like. So it starts at the bottom and then moves towards the top. So phase 1 is what I will talk about the most, just because that's what I've been involved in. And that is the orientation piece, where it's students from all of these schools coming together and learning together. Phase 2 and phase 3 are more advanced, and so an example of phase 2 here at the U would be, we have something called community teachers, and community teachers are actually patients who have been trained to work with students to talk about their experience being a patient in our healthcare system. And currently at the U, this only incorporates medicine, nursing, and pharmacy, but certainly they're hoping to involve other disciplines. Phase 3 is out in the community. Phillips Neighborhood Clinic would be an example of this. And so phase 3 has involved students from nursing, medicine, physical therapy, pharmacy, public health, and social work. And in the Phillips Neighborhood Clinic, for those who don't know, all care is provided free of charge, and most of the services are provided by students who are supervised. And one of the really cool things about the PNC is that it actually includes legal services as well for patients. But so FIPSI is sort of the foundation and where people are getting the basic knowledge. And like I mentioned, pertinent for people in the audience is that anyone now who goes to medical school here is going to participate in FIPSI in their first year. So it's a little premature, I think. I don't know that our first-year residents would have been in FIPSI, but certainly have they? Oh, there you go. I was wrong. Thank you. Certainly then, if it's already happening, then in subsequent years, any resident who comes from our medical school will have gone through FIPSI. And so it is still relatively recent, and every year it goes under major reconstruction. But or at least this past year, it incorporated more than 1,000 students across all 3 campuses, so here in the Twin Cities, as well as Rochester and Duluth. And then they are divided into groups. And so last year they had tons and tons of groups with 12 students per group. There was variable feedback about the facilitators, and so they made the decision to have far fewer facilitators since it's all donated time. And instead, this past year, we had 35 students per group. And then within the 35 students, they were then broken down into smaller groups of 5. And then every group so you had 5 students, all representing different disciplines. It gives me a headache just thinking about the people who coordinated that. But, and so as far as what we were teaching, so this should line up exactly like I mentioned with the core competencies. So in the first lesson, we not only talked about the rationale for IPE, but also this idea of roles and responsibilities. And one of the activities was specifically hoping to address that concept of stereotypes, that like with anything else, there are lots of stereotypes out there about the different professions, and getting everybody in the room to talk about them early on is intended to sort of break some of that down. Next would be provider well-being, and so this isn't necessarily one of the core competencies, but as I mentioned, if we're going to try to address burnout, the hope is to be teaching people in their first year of school about this concept. One of the activities was a mindfulness meditation, which for those of you who know what I do, I was super pumped about this. And then I go to play it in front of my classroom, and the script didn't work. So that was unfortunate, but a nice opportunity for me to practice stress management. And the group was accepting of that. 3 is teamwork. One of the activities is the Marshmallow Challenge. I don't know how many people here are familiar with the Marshmallow Challenge, but I have this pipe dream that we're going to do it in clinic someday, so I won't actually tell you about it. But the goal being to get everybody working on the same goal. And then there also was discussion of particular cases that required teamwork, and specifically that idea of the patient as being a part of the team. Ethics, not surprisingly, we started just by talking about similarities and differences in different professional codes, the ethics of team-based work and common violations, and really interestingly, this year there was a whole section on the ethics of social media, with examples pulled from different students from the U, from different disciplines that had made a pretty big oops. So how to learn from that. Number 5 was health systems. So this is where we really educated people about things like the triple aim and why these matters, or why these topics matter. And then lastly, session 6, unfortunately I wasn't there, but my co-facilitator was, and this was every group had to put together their own TED Talk on the importance of teamwork, and then they were submitted and people voted, and yes, Dr. Realmuto.
Thank you for taking my question.
That's teamwork.
Yes. There's 6 items on this.
Yes.
It would seem to me 5 of them could be done in parallel. I don't need to be sitting next to somebody who has a different discipline to learn about ethics. Perhaps a discussion with a different discipline and their perspective would make it more interesting. But essentially, except for number 3, it seems to me number 3, the only way you could do number 3 is to be talking and finding language that creates a better relationship among the team. So could you say more about number 3?
Yes, so thank you for the question. So just to stick with number 4 first, so for example, the case that they come up with, they do a really nice job of making sure that the case in some way involves animal health, so that one of the topics that comes up is the idea of euthanasia in veterinary medicine and why euthanasia is on the table. And then it leads to an interesting conversation about how, in general, euthanasia isn't practiced among physicians, but then, in California now we're talking about there is such a thing as patient-assisted suicide. And so all of the academic work happens before the class, so that in class it actually is pretty much all discussion. And it's both small group discussion first and then larger group discussion. And one of the things to teamwork is that at the beginning of the course, everybody is actually assigned their own role. So like 1 week you're the leader, 1 week you're the observer, 1 week you're the reporter, so that then when you have these small group discussions, somebody has already been identified as who's going to share with the larger group what your conversation was. In this case about, I think there was something with cows that were sick, and the question was, do you euthanize the cows? But it turns out the cows got sick from the humans and not vice versa, and things like that. So, so that's to number 4. But you wanted me to say more about 3?
Yes.
Just in terms of what's included?
My point was, number 3 probably has to do with relationship building.
Yes.
So I could have my own discipline knowledge and you could have your discipline knowledge, and we could know that we're different and where we overlap.
Yep.
But when I talk to you and you talk to me, that relationship has something to do with how effective our team works. And so that's why you need to have the group rather than
and the common
individual
language.
Disciplines. So that, maybe you could say something more about that.
So basically the way that I'm hearing your question is sort of how is the different material taught so that it matters that we have different disciplines in the same room as opposed to having them separate.
Let me break it down to simple.
Okay.
Marital therapy.
Yep.
People live together for 50 years,
yep.
and they don't know how to talk with each other.
Yep.
Okay? They know their roles, responsibilities, what,
but they don't communicate.
You cook, I do this. But we can't talk.
Yes.
Can we talk?
Yes. And so one of the things that is taught in number 3 is this idea of trying to move away from having less hierarchical teams. The hope being that if we can break down hierarchies, in part by understanding everybody's role and contribution, that actually will facilitate greater communication. That one of the things that most interferes with communication is a hierarchy where it seems as though one profession's input may matter more than somebody else's. And the hope is that if we, from the first year of school, are teaching people that everybody's voice matters, then everybody will contribute. Did that address it better?
Being respectful.
Being respectful.
It's important in teamwork.
Yes.
Okay, got it.
Thank you. Okay. So that's just a little bit of what's going on here. In terms of what's going on elsewhere in the country, these are just some of the highlights. So Kansas is the group that actually just last week was here, putting on a workshop for people from here as well as from lots of other centers in the Twin Cities. And just one of the things that I highlighted is just how collaborative their relationship is with the law school. And so like I mentioned at PNC, you can consult with legal aid, but at Kansas, that's like a really large portion of it. So that if for any particular patient you've got a legal concern, you can make a referral and it gets addressed immediately. At MUSC, they have another large center doing this work. And certainly here at the U, they are invested in the faculty development piece, because if we're going to be teaching people, if we're teaching our learners this material, certainly faculty need to know. But at MUSC, this was a really large portion of their program, not only in terms of how to teach this material in the classroom, but then how to teach it in clinics and on the units, and then lastly, how to evaluate the outcomes, which I think is pretty cool. And then Thomas Jefferson, so I had mentioned that here at the U we've got community teachers. At Thomas Jefferson, they call them health mentors, and this is one of the things that they really pride themselves on in terms of how to train patients to be teachers, and then how to train learners to actually learn from what their patients have to offer. And just one example of a collaborative practice clinic is the Falls Assessment Program, where they have both providers as well as students from PT and OT, medicine, nursing, and pharmacy working together to figure out what might have contributed to a fall and how to prevent it. And then looking globally, there was a group that came from Montreal and did work here, and there they refer to it as patient as trainer. And I don't say this to sort of like beat a dead horse about the same topic, but I just think before I was familiar with this work, I really was not at all familiar with the idea of patients being the teachers. And clearly it's in vogue right now, and there's literature to support how this is useful, because not only do learners get to learn from patients, but it actually is a way for patients to give back to the healthcare system if they feel like they've really benefited. And I should add, in case people are wondering, no matter what the school is, there is a lot of training that patients go through in terms of what it is that they're hoping to get out of being a trainer, what they're going to be teaching, and things of that nature. The World, I won't even read it because it's too long. And so it goes by WCC. And what's really cool about this organization is that it represents the US, the UK, Canada, Europe, Japan. The Nordic countries have their own group, and then Australia and New Zealand. Altogether, Better Health is their conference that they put on every other year. And I will definitely be sitting it out in 2016, but I'm hoping in 2018 to go to New Zealand and maybe get some funding to do so. So if I have sufficiently piqued your interest and you want to do some sort of interprofessional work with me, maybe we can go to New Zealand. And then lastly, there are efforts in developing countries, certainly in countries like Egypt and Thailand. Some of the health systems issues that they're facing are far different than ours. But nonetheless, this is taking hold there as well. Okay, so Amina in the Nexus was actually put together by the National Center here at the U. Amina is a fictional patient, but she could be anybody's patient. And the Nexus is this idea that was created to represent the intersection of patient care and education. The U and the interprofessional education writ large community is aware of the fact that often it feels as though patient care and education missions are in conflict with one another, and it feels like we can only do well at one of them at the expense of the other. And the hope is really that we can create learning opportunities where that is more of a synergistic experience. And so that is what Amina is.
Meet Amina. Amina is striving to manage her diabetes and maintain her health. She has a key role to play on her care and learning team. Amina uses a mobile device to stay connected to her team. Each morning, Amina measures her blood sugar. Today, she noticed it seemed high, as it had been yesterday. Her glucometer automatically reports her glucose measurements to her local community health center, which is funded as a federally qualified health center. Linking education and healthcare delivery systems. A few years ago, the university administration identified faculty and provided resources to create a curriculum committee, whose charge was to redesign the health sciences curricula to advance the triple aim and create a nexus integrating practice and education. Now, students learn together in courses, rotate through communities in interprofessional teams, use state-of-the-art learning technologies, and are assessed for team competency throughout their education experience. For several months, students are placed in one health system so they have time to fully engage in care delivery, complete quality improvement projects, and add value to sites. Building innovative partnerships. Amina's Health Center partners with the Somali Community Development Alliance and the university to ensure members of her care and learning team deliver her care in a coordinated and culturally respectful way. Because practice is integrated with the educational system, patients and learners experience a new meaning of quality. And the partnership demonstrates shared responsibility for the health of people like Amina, as well as for the health of the community. The partnership between the FQHC and the Somali Community Development Alliance provides a team-based, patient-centered health home, with the patient, community, providers, and learners as part of the team. The results of the partnership. Population health in the urban community is now similar to that of the suburbs. Transforming healthcare for Amina. The computer that receives Amina's blood glucose reading reviews her record, recognizes an increasing deviation from her usual pattern of control, and alerts others on her healthcare team. The team receives the alert via Amina's electronic health record and assigns the pharmacy student under supervision of a nurse clinician to engage the Somali community health worker. Speaking in Somali, the community health worker calls Amina and reviews cultural, diet, family issues, and Amina's current self-care protocol. Soon after, a conference call is initiated among the pharmacy student, nurse clinician, community health worker, Amina's primary care practitioner, and Amina. They develop a plan. Amina walks to the clinic a few blocks away, leaves a urine sample, and has blood drawn. A few hours later, following a treatment plan review, the pharmacy student discusses the urinary tract infection diagnosis with Amina and the community health worker. The pharmacy student confirms Amina's medication allergies and pharmacy of choice. Amina starts taking her antibiotic within 2 hours. Later that day, the team huddles and reviews Amina's case, including the FQHC care goals for diabetes and the care processes and outcomes. Healthcare students reflect on their interprofessional experiences with Amina and other patients. They update their electronic learning portfolios. A team of faculty, practicing clinicians, and community members assess each student's portfolio. They base their review on previously established profession-specific and interprofessional competencies and standards. Over the next few days, Amina sends text messages to the team members to update them on her symptoms and blood glucose levels. The other team members text Amina with information and reminders about her health goals, self-care plan, and scheduled group visit. Since Amina became a member of the care and learning team, she no longer requires frequent hospital and emergency care. Amina is now healthier and more engaged in managing her own health as a result of this new care model.
All right, so when I watch it, perhaps it feels a little bit idealistic and like everything just works together really seamlessly, and you gotta have a goal in order to move in one direction. Personally, when I watched it, my first reaction was just about the role of technology and how pervasive it was, more so than the teamwork piece, but that's a whole other topic. So just in terms of collaborative practice and interprofessional education, some of the things to highlight, as it mentioned that there's a pharmacy student, but the pharmacy student is working under the supervision of a nurse clinician. And so one of the things that interprofessional education raises is the topic of accreditation, and that different professions do have their own requirements in terms of who you get your supervision from in order for it to count. But certainly the hope is that if healthcare is moving in the direction of interprofessionalism being more important, then there's no reason why it can't sort of count for credit to have supervision from somebody who's of a different discipline. Another key topic is this idea of team huddles, and certainly team huddles may be happening in certain places. Currently, we don't have huddles in clinic. I would love to have huddles in clinic where we actually bring everybody together in the beginning of the day or maybe in the middle of the day to talk about who's in clinic and what kind of care they need. There's obviously lots of logistical barriers to that, but I can dream. And then two final things. One is that idea of that the educational review process is happening by multiple people in different places. So it's not just faculty, and I realize milestones are this afternoon, so it's sort of perfectly timed, but that you would be getting feedback from people in the community on topics not only of profession-specific competencies, but this idea of working in teams. And then lastly, it was mentioned that Amina is a member of the care and learning team. So again, really highlighting the importance of having the patient be a part of collaborative practice. And more importantly, that Amina is also part of the learning team. So going back to that idea that learners can actually learn from patients. The other two websites that are listed here are just two resources. So the bottom, this one, the AHC one is all the things related to One Health. So if you're interested in FIPSI or learning more about what's going on here at the U, that would be the link. And then the Nexus one is a site where you need to create a login, but it's totally free. And then it has access to any and everything you could possibly want regarding interprofessional practice. So it's got videos, it's got tutorials. It's a really great resource. And then lastly, I couldn't find a link to it, but the National Center here at the U will be putting on a conference in August, so if this is of interest. In terms of acknowledgements, the folks on the left are all of the people that have worked together with me in some capacity with FIPSI, so from faculty mentors and people who run the program, to the bottom three being students who have actually participated in FIPSI. And then, like I mentioned, we did just have this workshop last week, and clinic was represented, and so I was thrilled that Kristen Brozak, our clinic manager, went, and then we had representation of a social worker as well as a nurse. And then I managed to corral 2 residents to each spend half a day so that not only was psychiatry, medicine represented, but the learner experience was also represented. So those are my references, and that's it.
Thank you. Questions?
Sorry about this. When individual practice, the driver is you do something and you get paid.
Yes.
It's a very simple system. What are the drivers for this? For example, you either do team practice or we don't employ you. So that would be an employment policy driver. Can you unfold for us what you think the drivers of this are as we move forward?
A little bit. So Number one, I will just encourage people who are interested in the drivers to look into the annals of, or no, wait, the very top one, all about the triple aim. That article talks all about the drivers, and the key piece being this concept of integrators, whose role is going to be to address health outcomes as well as cost and things of that nature. I can direct you there, but a lot of what integrators do is, like, sadly over my head. But, yeah. Yep.
Is the insurance industry a driver?
Yes. Certainly the insurance industries would be part of what an integrator would be paying attention to. Yeah. And the insurance industry obviously is the one who has the biggest, well, clearly patients have a very large stake in it, but the insurance industry certainly does, given that they're the ones who are concerned about cost.
The other drivers are accountable care organizations who are, as part of their compensation, gets linked to patient experience outcomes. They're looking at how can they tie providers' compensation, or even a small component of providers' compensations, to measures of professionalism or patient experience outcomes. So one new role in organizations that we're seeing is chief experience officers, who will be involved in sort of looking at that and integrating that into the organizational approach.
Great, thank you. And to that point, in terms of the experience and satisfaction, I know that when I joined faculty, there was one workshop that I went to where the satisfaction piece was really highlighted, and that, when you get those satisfaction surveys in the mail, and it's like a 5-point Likert scale, and in order for it to count, that the person has to give you a 5, and if they give you a 4, that's not adequate, and we need to improve. And that sort of drove me crazy. And at the same time, I do get that you can go to a provider, get a bad diagnosis, or the treatment can be really challenging, and nonetheless you can be satisfied and still feel like you got the best care for a challenging condition. And so I think the idea of satisfaction and experience can sort of cut both ways.
Sasha, I think when I think of integrated care, the first thing that comes to my mind is Mayo. And maybe that's slightly different, but you didn't mention Mayo is the Mayo model, which has existed for a long time with integrated clinics, highly integrated clinics. Is that on the radar? Is that along the lines, or are you maybe familiar with it at all?
Yep, the Mayo Clinic certainly would be. I thought about presenting some information from the Cleveland Clinic. Perhaps I went with the information that's been most highlighted by the other things that I've been to, and so I don't know if maybe Mayo has been under-highlighted as our competition, but certainly Mayo would be a model of who's doing this already.
Last week we heard the third candidate for the Department of Chair using technology to advance our health needs. A couple of days later, we heard of this terrible massacre in San Bernardino, California. And a few days later, we heard our president talk about an approach to make friends and integrate and work with the Islamic community in a way to spot and redirect radicalization. Mm-hmm. My question is, in the model that you put out so nicely, do you see a possibility of using this kind of technique or technology or alliance building that could put us in tune when something is amiss and some young man is thinking about becoming radicalized?
So that's a softball, San Bernardino and the president and technology and healthcare. So I will do my best. But yeah, certainly I think that there is a role that technology can play in terms of identifying people. I think, again, like satisfaction and experience, technology cuts both ways. It has awesome powers, and then with power and opportunity comes a lot of risk. So I think how we think about monitoring people and things of that gets a little bit dicey, but certainly I think the more that we're connected to communities and people, the easier it will get to identify people. But I think it goes back to that idea of having the patient or having the community have a voice at the table so that it's not providers in the system coming in, but they actually are an equal contributor.
Sasha, great presentation. Given that we have sort of interdisciplinary professionals all in this department, do you have ideas about how we could be more integrated either in our clinical work or our education efforts?
Great question. So at the end of last week's workshop, I had all sorts of ideas. I think, in my mind, I think it's easier to think in terms of integrating our educational missions before the clinical piece, just because the clinical piece feels a little more daunting to me. But so a very simple example would be that how we can integrate the child psychiatry fellows and the child psychology interns better. And so at one of our child division strategic meetings, I had brought up that we have a huge missed opportunity as well as burden in terms of having separate didactics. And so Dr. Miller gave what I'm sure was a phenomenal talk on suicide risk assessment to the interns. I gave what I hope was an interesting conversation with the fellows. That was double the burden of having it be me and Mike, and there was no reason that the two groups couldn't be together to sort of talk about their own approaches. That would be one. At the end of the workshop, I was talking in terms of, is there a way for us to get even more students? So we've got pharmacists now, we have nurses, we have a social worker. Can we get more students? That's a longer range goal. And then in terms of clinical practice, like I said, a huddle would be a perfect thing, but figuring out how to address green space and unfilled visits and things of that nature with taking out time to meet is the challenge. Clearly the data is there to support that it's worth it, but yeah.
So I'm wondering what are the lessons learned about increasing buy-in amongst the students? I actually was, I think, the first class as a medical student to go through the FIPSI program.
A guinea pig.
Yeah, and I actually had an opportunity to work for 3 years in the PNC, so I think that I was fortunate because I had a lot of experience with interprofessional education and training, unlike a lot of my colleagues in medical school. But I remember when I was first going through the FIPSI program, aside from all the hiccups sort of a new program, it felt a little forced.
Yeah.
And I'm wondering if that's changed. There's an element of teaching specific skill sets for interprofessionalism, but there's also an element of it's a broader cultural shift, and you have to establish some buy-in amongst all these different folks involved. So I'm wondering what you've learned and what you've noticed. Are students enjoying this more, or what's going on?
So in terms of are they enjoying it, I don't know, they haven't compiled the data yet in terms of this year's cohort just because it just ended in November. But I totally agree that I think until this is sort of what's being practiced in the real world, so to speak, teaching it to first-year students, even if they get it and they're excited by it, it's going to fall flat. So that's why I wanted to give this talk, and and that's why I'm glad that the center is doing things for faculty development. My hope would be that as the people who are going through FIPSI now progress through their training, you and others will eventually be the leaders and the teachers who will sort of support that culture. But Brian Sick, the physician who is at the head now, and their whole team recognizes that it does require a culture shift, but you have to start somewhere. So, and in terms of last year's feedback, I think it was mixed. There were certainly things that people enjoyed and things that they didn't. And so that was one of the reasons why, for example, the Marshmallow Challenge was brought on to do more team-based work and have it be more applied.
Sasha, just when you're talking about this, what other individuals outside of the university, I mean, you kind of talked about different meetings, and who else like in our community is really participating? Because I can see some organizations that are training-based that do a lot of that, and then private organizations that, quite honestly, might be some of the biggest challenges in terms of communication and coordination. Are they participating in this? And if not, how do they?
Sure. So last week, for example, Wilder was there at this workshop, and Wilder apparently does have students from multiple disciplines. Wilder had actually received some grant support to explicitly do some interprofessional education, but only particular disciplines were involved. And then outside of the U, besides Wilder, nobody else comes to mind. The Coot Clinic was there, Women's Health Clinic was there, there was a group from Duluth. So it does need to...
So nonprofit, we treat the sickest of the sick folks or folks. I mean,
Yeah.
the for-profit, I mean, that, because I think that's part of the challenge is, you know, and sort of along the billing side, it's like, how do we get the for-profit people involved? Because the for-profit folks,
Yeah.
billable hours they use.
Yeah. And like with anything, there's going to be winners and losers and
Yeah.
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 But yeah. Well, one might hope that maybe that's where provider well-being would come into play, that even if you're a loser financially, that if you manage to retain well-skilled providers who don't get burned out, perhaps that's a net increase for a system where other systems might lose burned out providers because they just can't do it, maybe.
Well, thank you so much. And I just wanted to do a quick plug on the topic of interprofessional education. We actually do have some innovative educational models on our inpatient units that we take for granted, where there's multiple disciplines in one room caring for the patient simultaneously. And we take it for granted and do a good job with this, but we're not really getting credit for this innovative work we're doing because we haven't been able to implement one more step, which is that of a student reflection on the process or some kind of guided examination of the impact of this model.
Yeah.
And so anybody looking for a small project that's pretty much mostly formed and would not be a lot of heavy lifting, whether it's medical students in the audience or residents or faculty members, if you want to let me know if you're interested in this area, it would be pretty easy to implement if you only have a small amount of time and pretty high yield on a topic that is up and coming. And so that's an opportunity I wanted to throw out there at the last minute. And thank you so much.
And then you can go to New Zealand.
Go to New Zealand.
Yes. Thanks.